Hi, I'm Dr. Pavitra and today we'll be discussing about the basics of mechanical ventilation. So I'll be dealing with it in two parts. The first part is where we'll be discussing terminologies, I would say, rather than the basics. First, let us know what the different terms mean because not all of us are experts in it, isn't it? So let's start from basics. So the part one is where we'll be talking about the human side of mechanical ventilation, terms related to humans rather. And part two, we'll be discussing about what are the terms when you use when you're using a ventilator. So only if we know those terms, then we can go ahead and learn different modes of ventilation, how to initiate, when to initiate, all of those. So let's get started. So at the end of this presentation, I hope you will learn the different terminologies in lung volumes, compliance, resistance, elastance, and work of breathing. What is respiration? Is it just taking in air, putting out air, or is it taking in oxygen and putting out carbon dioxide? Or is it the cells taking in oxygen and exhaling out carbon dioxide? Which is it? So this process of what your lungs are doing is external respiration. What the cells are doing is internal respiration. And the internal respiration is the ultimate goal. Okay, it's not enough if you just take in oxygen, it crosses your alveolar membrane and the blood carries the oxygen to the tissues. The tissue should be able to utilize it, and that is what you want at the end of the day. Okay, so spontaneous breathing is the movement of air into and out of lungs as a result of work done by individual's respiratory muscle. If the same work is done by means of application of positive pressure to the airway, then it is a positive pressure ventilation. If you want it very, very simply, spontaneous breathing is you increase the negative pressure on the inside, so the air is pulled in. If air is pushed in, then that is positive pressure ventilation. So pulling in of air is your spontaneous breathing, normal breathing. Pushing in of air is positive pressure ventilation. The composition of gases, we have been reading it for such a long time from our school days. 21% of air is occupied by oxygen, correct? So what is the partial pressure of oxygen? If you know the total pressure, then you can calculate it from this 21%, isn't it so? So total pressure, you standardly put it as 760 millimeter of mercury at sea level. But what is not accounted for here is the water vapor pressure, correct? The air has humidity in it. Your respiratory system humidifies the air that goes in, correct? So the water vapor pressure at body temperature of 37 degrees Celsius is 47 millimeter of mercury. So at the end of the day, what I'm trying to tell here is from the 760 millimeter of mercury, 47 would have gone for water vapor pressure. The rest, from the rest of the pressure, 21% is being occupied by oxygen. So it's not 160 millimeter of mercury, it is 150 or 149 to be very specific millimeter of mercury is the partial pressure of oxygen in air. And gas is always diffused from areas of high pressure to low pressure, and the rate of diffusion or the speed of diffusion depends on the concentration and the type of barrier between the two areas. This is a standard diagram in most of our physiology textbooks. All of you must know this. So there are 23 generations in our airway, correct? The first 16 generations are separated by a horizontal line from the next 1, 2, 3, 4, 5, 6, 7 generations, correct? The reason is the first 16 generations do not participate in respiratory exchange or exchange of gases, okay? It does not actively participate in the so-called respiration within quotes, okay? So there's no gas exchange that happens. So these are called as conducting airways because they just conduct air, or in other words, they can also be called as dead space, anatomical dead space. Okay, so dead space is where you have air, but that does not participate in gas exchange. So if this is an anatomical dead space, if something is named anatomical, then there should be something physiological, correct? So what is physiological dead space? Physiological dead space is secondary to the presence of, okay, I thought of giving this as a question. All right. So physiological dead space is caused secondary to thespian veins and bronchial vessels. So let me see who tells me what is thespian veins and bronchial vessels and how is it going to contribute to a physiological dead space. So let me know down in the comments below. I would like to know your answers. Okay. So now that we have covered anatomical and physiological dead space, now if there is something physiological, then there should be something pathological. Correct? Correct? So what is a pathological dead space? And what is the corollary of it? So let me try to put it with a, there is a alveoli here. Okay. From the blood and goes in. The correct, very basic thing. Isn't it so? So if the ventilation does not happen and only circulation happens in this area, then there is no gas exchange happening, correct? This is one scenario. Another scenario is where blood vessels are not having blood at all, but air is circulating in the alveoli, correct? So two opposite situations you're having here. So in this situation where perfusion does not happen, but just air is coming in and going out, is pathological dead space. Okay, this pathology is very simple. Now what will block the vessels? Any thrombus, any embolus. Okay, so pulmonary embolism can be kept in mind. The opposite situation where we talked, circulation was happening, correct? But air was not coming in at all. So any condition that will cause alveolar collapse or alveoli being filled with fluid, so that will result in a shunt. Shunt is where the blood flows in and out without participating in gas exchange. Okay, so dead space is air flowing in and out but does not participate in exchange. Your shunt is blood is flowing in and out without participating in gas exchange. An example of this will be your even your pneumonia. Severe pneumonias can cause, your acute respiratory distress syndrome will cause. Okay, so this is anatomical, physiological, pathological dead space and shunting. Mechanics of respiration, I think all of you will know, diaphragm is the main muscle that participates. Two mechanisms, bucket handle where the chest wall moves by means of intercostals, and pump handle mechanism where the sternum moves by means of sternocleidomastoid. Okay, the chest wall goes down and the sternum goes up, resulting in expansion of lungs, providing more surface area, more negative pressure in fact for the air to enter in and participate in gas exchange. So what keeps the lung inflated? Okay, so expansion, yes, still expansion we saw, but what makes it stay that way? What is it that is preventing it from collapsing upon itself? It's an elastic structure, isn't it? So it should come back to its normal shape. So the chest wall and the lungs are in contact with each other. Okay, both are elastic structures, your chest wall and pleura. And there's a thin layer of fluid between the chest wall and pleura. So imagine two glass slides, okay? So if there is fluid in between those two glass slides, you will be able to slide it across each other, but you will not be able to pull it apart, isn't it so? Try this small science experiment. I think all of you must have done it at some point in time, correct? So two glass slides, if there is no water in between, then you can slide, you can pull it apart, you can put it back together, all of those. But if there is some water in between, then it tends to like stick with each other and move along with each other. But trying to pull it apart is going to be difficult. And that is what happens here. So at end expiration, even though lung tries to collapse inward upon itself, the chest wall tries to recoil outward. So this opposing forces balance each other, resulting in lung remaining open, even at end expiration. Okay. So if chest is open due to any reason, then this force is lost and lung collapses. And if lung collapses due to some reason, then chest wall has nothing holding it in place and it becomes barrel shaped. So that is what happens in your COPD patients, isn't it so? So your chest wall becomes barrel shaped. Emphysema, chest wall becomes barrel shaped. Okay. So any condition where lung loses elasticity, basically, it need not collapse upon itself. I should put it in a better way. I'm sorry. If lung loses elasticity, then the chest wall becomes barrel shaped. Okay. If the lung is going to, collapse so-called, then it will pull the chest wall along with it, resulting in your crowding of ribs. You will be clinically able to make out that the lung volume has been lost. Okay. So this balance between the lung recoil inward and chest recoil outward will determine the lung volume at the end of expiration. What is transpulmonary pressure now? See, transpulmonary pressure is something from, there are so many pressures, right? There is airway pressure, then there is alveolar pressure, then there is pleural pressure, then there is lung elastic recoil pressure. There are so many things. So what is pushing the alveoli outward? Now we are coming into the alveoli. So far we have been discussing lung as a whole. So what is pushing alveoli outward is your alveolar pressure. And what is trying to collapse it is your pleural pressure and lung elastic recoil pressure. Transpulmonary pressure is the difference between alveolar and pleural pressure. And this should be equal to your lung recoil pressure to make sure the lung remains open or the alveoli remains open. So what can you do to increase transpulmonary pressure? Take this formula, correct? So transpulmonary pressure is equal to alveolar pressure minus pleural pressure. Okay, so let's put it very simply. So if you want to increase this transpulmonary pressure, or if you want to distend the alveoli, you need to increase this alveolar pressure, correct? Or decrease this pleural pressure. Mathematics, simple mathematics. So how can you increase this alveolar pressure? That is by your positive pressure ventilation. How can you decrease pleural pressure? That is what is happening spontaneously by means of increasing the negative pleural pressure. Correct? So pleural pressure becomes more negative, pulls in air, isn't it so? So this is what happens in spontaneous ventilation or negative pressure ventilation. Okay. So if you want alveolar distension, you need to increase positive pressure by pushing in air or decrease the pleural pressure, which usually happens spontaneously. So this is another diagram which depicts the fall in transpulmonary pressure associated with increase in lung volume. Okay. Are you able to make this out? So during inspiration, there is a negative pleural pressure. See, compared to the alveolar pressure, your pleural pressure dips more, resulting in pulling in of more air. So this is inspiratory phase. During end inspiration, lung recoil happens. So lung recoil begins to pull the chest back into expiratory position. Airway pressure becomes more positive and expiration happens. Expiration is usually a passive process and it is not active. So let us see the difference between a spontaneous ventilation and a positive pressure ventilation. So when the inspiratory muscles contract, the intrathoracic volume increases and the pressure decreases. Pleural pressure decreases. And this results in increased transpulmonary pressure, resulting in gushing in of air, resulting in increased lung volume. Okay. After this increased lung volume, what happens? The air diffuses out of the alveoli into your blood vessels. Correct? Your oxygen gas exchange has to take place. Correct? Then after that, your expiration happens. Expiration is a passive process, hence we are not discussing it here. In positive pressure ventilation, you are not going through all these steps. Okay? Directly ventilator increases the proximal airway pressure, pushing the air into lungs, increasing the alveolar pressure, increasing the transpulmonary pressure, and increasing lung volume. Here the order of things are changed. Okay, so if you notice this, you will know. So Q is the airflow. This airflow is dependent upon change in the pressure from airway to alveoli, correct? Only if airway pressure is more and alveolar pressure is less, it will move from the airway into the alveoli, correct? But there is one more factor that we need to consider, that is resistance. We will talk more about this in the next few slides. Okay, so if the proximal airway pressure is equal to alveolar pressure, what happens? No flow is going to be present. Q will be equal to 0. Normally, this state of equal pressure happens in two conditions, or rather I should say two states, during a single breathing cycle, at the end of expiration and at the end of inspiration. Okay. So till now we saw so many pressures, correct? Positive airway pressure, negative pressure, spontaneous airway, what happens, then your alveolar pressure. Now let's talk something about volume. Okay. This is a standard diagram again in your Guyton, Ganong, almost all physiology books, respiratory physiology books, you'll be able to find this. Too many volumes, isn't it so? It's actually very simple. So normally when you are breathing in and breathing out, the air that moves in and out is your tidal volume. Simple, correct? So suppose you are taking in a normal breath, but gushing out air, or your expiration is forced, you are pushing out more air. So then this extra air that is coming out is your expiratory reserve volume. So that normally does not come out, but if you are pushing it out, it is going to come out. So even after this expiratory reserve volume goes, you have some amount of air left out in the lungs. This is necessary. No, you need some amount of volume to be there. If it is not there, then the lung is completely going to collapse. So this is residual volume. Even after forced expiration, whatever volume is left out is your residual volume. These two together, your expiratory reserve volume and your residual volume together, is called as functional residual capacity. This is a very, very important volume. This is what keeps the lung open after a normal expiration. And this air is important because, see, after expiration, or during expiration rather, even then you need some amount of gas exchange to happen, isn't it so? But when air is going out, where is the air coming in? So this air which is left out in the lung, functional residual capacity, provides the gas exchange during expiration. And this prevents lung collapsing after every expiration event. So these are all expiratory volumes. What about inspiratory volumes? Suppose after a normal breathing out, the patient is taking a deep breath in, correct? So deep breath in, this is called as inspiratory capacity. Okay. So after a normal breathing out, the patient is taking a deep breath in. That's an inspiratory reserve volume. I'm sorry. This is an inspiratory reserve volume. And this along with tidal volume becomes the capacity. Okay. So this inspiratory reserve volume along with tidal volume together becomes inspiratory capacity. Okay. So everything together, from your inspiratory reserve volume, your tidal volume, to your functional residual capacity, if everything is put together, then that becomes your total lung capacity. So when you are expiring out and the patient is forcibly expiring out, the volume that comes out in the first minute is your forced expiratory volume in the first minute. Correct? I think all of you must have come across this during your reading through asthma, isn't it so? So this is a measure of, can we say, an indirect measure of resistance of airways? Suppose the airway is not allowing air to pass through because of resistance. Then what happens? Your expired volume, forced expired volume during the first minute is going to be very less. Okay, so FeV1 is going to be less in conditions which increase the resistance of lungs. The importance of these volumes are tidal volume, you know. And what about minute volume? So the number of times a patient breathes in and out, that amount of volume is your minute volume. So this is what is participating in gas exchange. Is it so? Actually, no. Because we saw dead space, isn't it so? We saw something called as dead space ventilation. So alveolar minute volume is important rather than the total minute volume. The amount of air in the alveoli, that can be calculated by subtracting the tidal volume from the dead space volume, because dead space is not participating in gas exchange. Multiplied by the total respiratory rate will give you how much the alveoli is, ventilating in a minute. Dead space we already saw, functional residual capacity we already saw. This also we discussed, only source of gas available for gas exchange during exhalation. So any condition with reduced FRC, your alveolar oxygen declines rapidly throughout expiration, resulting in hypoxemia. So what will reduce FRC? Anything that collapses the lung inwards. Okay, so if it is filled with fluid instead of air, then your functional residual capacity is going to be less. Simple, correct? So examples will be your ARDS and pulmonary edema. To understand more about how the air is moving in and out, because all we are talking as if we are pumping air into barrel or a balloon and it comes out completely, correct? It's not as simple as that. So there are few things that you need to know. There are something called as compliance, there's something called as resistance, there's something called as elastance. So compliance is change in lung volume per unit change in transmural pressure gradient. Okay, so it is delta V by delta P. So for a unit change in pressure, how much there is a change in volume. So this depends upon the distensibility of the substance, correct? The compliance is of multiple types. There's a static compliance, there's a dynamic compliance. So let us see in a more simpler way. We'll see what determines the compliance and then come back to this. What determines the compliance of lung is most important surfactant, because that is what keeps the lung open, normal interstitium, posture of the patient, and functional residual capacity. Correct? So let us see pathological conditions so you'll be able to understand physiology better. So imagine your neonatal respiratory distress, preterm respiratory distress. So what happens in that? Lack of surfactant causes collapse of alveoli. Correct? So if the alveoli is collapsed, what happens? So if you want to give, say for example, randomly, let us assume you want to give 10 ml volume. Okay. Which do you think will be difficult? This is a normal alveoli. This is an alveoli that has collapsed because of lack of surfactant. Okay. So you need to give lots of pressure to this alveoli to distend it to 10 ml. Correct? Whereas here you need not put that much pressure. Normal amount of pressure will be enough to distend this normal alveoli to fill it to 10 ml capacity. Correct? In other words, this is a distensible alveoli. Lower amount of pressure is enough, whereas this is a non-distensible alveoli. So if you want to give this much amount of volume only, you need to put in higher pressures. Okay, so compliance is reduced. Here compliance is normal. What about interstitium? Again, the same principle you can think. Posture, say in a patient who's having severe kyphoscoliosis, it reduces the functional residual capacity. Anything that reduces the functional residual capacity will compromise compliance. Okay, so take it as a dictum. Anything that reduces functional residual capacity will reduce compliance. So what determines the compliance of chest wall? Is it enough if you know the compliance of lung? It is not enough, because chest wall is also important, isn't it so? Because chest wall is going to provide you the opposite pressure and preventing the lung from going down upon itself. So it needs to have a good compliance, and that depends on the bones and structural support and connective tissue, both. So in general, a high compliance is seen in diseases like COPD, imagine, where lungs can easily stretch, but they do not recoil back to normal. Okay. So it takes longer amount of time for the patient to exhale the volume out. So in that cases, what happens? Some amount of air remains inside the alveoli itself. Correct? Because airway is not recoiling back. So continuously some more amount is trapped, some more amount of trapped. This is what happens in COPD emphysema, isn't it so? Even your asthma. So, but asthma does not per se have, problem in recoil of lungs, but just saying air trapping happens. So it takes longer amount of time to put the volume out. So in such situations, air is unable to effectively come out, causing air trapping and hyperinflation. So this happens in high compliance situations. So high compliance also not good. What happens in low compliance? Low compliance, lung parenchyma is stiff, isn't it so? So it's not able to stretch easily. So this results in increased work of breathing from the patient side or increased pressure from the mechanical ventilation side. Okay, so both low and high compliance is not good. We need normal compliance. Okay, so this static compliance is what you measure in the absence of flow. You purely measure just chest wall and lung tissue compliance. Dynamic compliance is measured in the presence of airflow, and this airflow is dependent upon airway resistance also. So airway resistance is again frequency dependent, isn't it? So we discussed it in the last class, where a laminar flow will have a resistance being inversely proportional to the fourth power of radius, whereas a turbulent flow will have the resistance being inversely proportional to the fifth power of radius. This is bad. Okay, we do not want that to happen. So that is about compliance. Compliance is for a given amount of pressure, how much volume gets in, and it depends on the distensibility of the tissue, which depends on both lung and chest wall and different factors. There's a non-linear relationship between transpulmonary pressure and lung volume. So in an ideal situation, what would you expect? I give X amount of pressure, X amount of volume. More pressure, more volume, more pressure, more volume. So this is the sort of graph that you expect, isn't it so? But physiologically, it is not so. Because as lung volume increases, the lungs become more stiffer and less compliant. Why? Because when the alveoli is in normal position, the surfactants are placed close together, resulting in a lower surface tension and better expansion. But as the lung becomes more expanded, the surfactant molecules are placed further and further apart, resulting in lower lung volume at the end of the day for a given amount of pressure. Okay, so more amount of pressure will be required to achieve the same increase in lung volume compared to this alveoli. So the relationship is not linear, and higher amount of pressures does not necessarily mean the same amount of translation or same amount of increase in volume. Okay. The flow rate depends upon the time allowed for inspiration and expiration. Say if the patient is breathing very fast, so less time is available for both inspiration and expiration, correct? So if the air has to go in and come out with a smaller amount of time, then the speed has to increase. So for higher respiratory rates, you need more flows for the same going in and coming out to happen. And higher pressures will be required. Why? Because if flow is going to increase, what happens to the property of airflow? It becomes more turbulent. If it becomes more turbulent, what happens? The resistance increases. If resistance increases, this flow has to go against this resistance. So for that, a higher pressure will be required. Now, I think you are trying to see how everything is connected with each other. You cannot discuss pressure separately. You cannot discuss volume separately. You cannot discuss flow separately. All of them go hand in hand, each of them being governed by compliance and resistance of that particular tissue in place. Okay. But this pressure gradient is necessary to move air from one place to another, isn't it so? And this depends on the sum of the elastic properties, resistance properties of the lung and airways. Okay. So lung elastance and resistance properties, your chest walls elastance and resistance properties, and your airways resistance. This pressure gradient is taken into account to calculate the dynamic compliance. That's why I told dynamic compliance is dependent on your flow of air. No, dependent on, no, I should not put it like that. Dynamic compliance is what you measure as compliance when there is flow of air. Okay, so static is when there is no flow of air. So this no flow of air so-called is purely theoretical, because even if you stop the mechanical flow of air, there is still some amount of flow happening within the lungs due to different time constants, and that we will discuss in next class. Okay. The difference in change in pressure between the static and a dynamic condition is secondary to airway resistance. Elastance, on the other hand, is the property of substance to oppose deformation. Okay, it's looking like the alternate to compliance, isn't it, sir? It is actually correct. Compliance is 1 by elastance, or elastance is 1 by compliance. So delta, change in pressure divided by change in volume, is elastance. What is resistance? See, resistance is to the flow of air, something is opposing it, correct? This opposing frictional force is called as airway resistance. Okay, difference between pressure in the mouth and the pressure in the alveoli, it is divided by the flow of air, V dot. Okay, V dot is represented as flow of air. Then that is airway resistance. Okay, RAW is resistance of airway. And normally it's about 0.5 centimeter of water per liter per second to 2.5 centimeter of water per liter per second. And resistance is inversely proportional to fourth power of radius. This we discussed. So keeping this in mind, you can ask me a question. If radius is in fact, smaller radius is going to increase the resistance, shouldn't there be more and more resistance as the airway generation goes down? Because the radius continuously comes down, isn't it so? So can you guys think about it for some time? Pause it here, think, and try to answer. The airway resistance is varied throughout airway, correct, and it tends to be highest in the mid-sized airway between 4 to 8 generations. Okay, but further along, if you see, even though the diameter reduces, there is too much branching that is happening, correct? So even though the resistance increases, it is distributed between all these small airways, correct? So because of this distributed resistance, even though the overall resistance looks more, the individual airways resistance is less because it is distributed between these divisions of airways. Okay. So combined resistance is actually small at the end of the day. So if you put all of these together, there are so many things that are trying to collapse airway inward, collapse lung inward, or keep it always open. Too many things, isn't it so? So this work of inspiration that is required to actually push air in should overcome three things: compliance work or elastic work of lung and chest, your tissue resistance work of lung and chest, and airway resistance. If all of these are put together, then that is called as work of breathing. In a ventilated patient, the ventilator has to overcome, apart from this, the breathing apparatus also, because there are too many tubings, endotracheal tube that goes into patient before the air from ventilator comes in contact with any of these. Correct? Okay. So with all of this in mind, let's see what is time constant. Oh, I'm discussing it here itself. Okay. I thought it was in the next slide. Sorry. Okay. So time constant is very simple. Time required for pressure equilibration to occur between alveoli and atmosphere. Okay. So time taken for a single lung unit to fill or empty. So that is called as time constant. Please note that time constant may be different even between alveoli in a diseased lung. So normally one time constant is 63%. Okay. Three time constants is 92%. For 92% of the alveoli to be, no, for a single unit to be filled 92%. Five time constants is 99 to 100%. So 99% of the volume of alveoli is equilibrated with that of the atmosphere. How do you calculate this time constant and why is it important? A compliance into resistance is your time constant measured in seconds. Okay. So in a airway obstruction condition and in a compliance poor condition, what happens? Let's see. A time constant is the time required for one unit to fill. Okay, so that much you remember. Compliance into resistance. So imagine a condition with airway obstruction where resistance increases. If resistance increases, what happens to time constant? Time constant also increases. meaning the time taken for one unit to fill with air increases. So that means what should you be doing? You should be increasing the time for ventilation. To be very specific, the inspiration may not be a problem. The time constant expiration is a problem. What is time constant? It is both filling and releasing, correct? It is not just filling, remember that. Time taken for one unit, one alveolar unit or one respiratory unit to fill or empty x percentage. So one time constant is 63% will fill or 63% will empty. So here time constant increases. So you need to increase the time of ventilation, especially during the expiratory phase. So you do your ventilation in a child with increased resistance, with slow rates, high tidal volumes, with more expiratory time, because this alveoli is taking longer time to empty. Got my point? So another condition where resistance may be normal, but compliance is poor. Okay, so compliance is poor and the lung is stiff. It's not expanding at all. So what happens to time constant? Time constant reduces. What does it mean? If you're giving in amount of volume, it fills up this airway, and it is this airway or this alveolar unit is not going to expand further. Correct? Because it is stiff. So smaller time constant means smaller tidal volumes, but you need to ventilate properly. So you're going to give higher ventilation rates. So your time for your inspiration and expiration can be derived from your time constants. So time constants for alveoli might be different in the same lung because disease process that is affecting the lung may not be uniform. So that is what this Pendelluft concept means. Pendelluft is displacement of gas from a more recruited non-dependent lung region to a less recruited dependent lung region. So imagine two alveoli. This is one nice good alveoli and this is a bad alveoli. Okay, bad alveoli. So what happens? So one has a good filling capacity, it fills, but this one takes a long time to fill. Imaginary, okay? I'm quoting, this is imaginary. Suppose this is taking a long time to fill. What happens? This alveoli is feeling sorry and it is putting in some air. Okay? Or in other way where a small lung is very stiff, so this fills with air earlier, whereas another alveoli which is normal may take some more time to fill with air. So can you see there are difference in time constants? Correct? Different time constants for different alveolar unit within the same lungs. Pendelluft phenomenon is where there is displacement of gas from a more recruited non-dependent region of lung to a less recruited dependent region of lung. Okay. So depending upon whether the resistance is more or the compliance is less, then your time constant varies. So imagine two lung units now. Okay, so there is one lung unit here and there is another lung unit here, and this one has more resistance. Okay, two times the resistance compared to that of this first alveoli. So what happens? The time constant is obviously going to be different, isn't it? So this resistant unit will be getting in air only at half the rate compared to that of this alveolar unit, which is filling at 1, if you put it like that. Okay. So what happens? If inspiration is prolonged, then this will also be able to fill as much as the first normal alveoli. Correct? But if inspiration is stopped early, what happens? And expiration is not happening properly, this one will empty well, because this does not require any special measures in terms of time of ventilation. Whereas this one, what happens? There will be a pressure gradient between the units because compliance is the same, and gas will redistribute from the low resistance unit to the high resistance unit. Because this good one will see that, oh no, this is only half filled, so I will try to help this out. Another situation where two lung units, Engappa, there is no place at all, no? Where will I draw? Where will I draw? Can I erase it? Yeah. Okay, good. So here there are two units, okay, two lung units, and one is having a poor compliance, okay. So there is a poor compliance or half the compliance of the other unit. Which one we will take this one, okay. So this one has half the compliance. So time constants are again unequal, isn't it? So here time constant is small, here time constant is normal, or compared to this time constant is reduced in the less compliant area. So this one will again fill at half the rate of other. Poorly compliant unit will fill at half the rate of other. If inspiration is prolonged, both will reach the same pressure. Volume in the poorly compliant unit will be half that of normal compliant unit. Okay. During inspiration, the pressure rises more rapidly because this is stiff and this is not allowing for expansion. The pressure increases rapidly in the poorly compliant unit. And if inspiration is stopped and expiration is also prevented, what will happen? This stiff lung will redistribute this air into the more compliant unit. Okay, until the pressures are equalized, because here there is more pressure, here there is less pressure. Got my point? This is the importance of time constant. So I think we have covered, at least touched upon the important points. If any concept is not clear, let me know, I will explain it again. If I made any mistakes, I'll definitely put it up in the description box below. So in conclusion, the mechanical properties of the lungs is a determinant of interaction between ventilator and the patient. The pressure gradient is what is going to drive the flow of gas, and the pressure gradient necessary is determined by compliance and resistance. Okay, so thank you all for listening to me patiently. I know this may not be the cup of tea for many of you, but this will help students who are taking part in the ventilation workshop and people who are interested in ventilation. Thank you all. Teachers, if you find something to add on to, or if you have made any mistakes, please let me know. So I will also learn and students also can learn. Thank you.